Open the video. Greetings, everybody. A rousing welcome. Hey, Vlad. Hey, Vlad. Vlad, are you there?
Hi, John.
Hey, how you doing today?
Doing fine. You?
Hey, listen, do you want to be the moderator today?
No, thank you.
Okay.
I'll just listen.
Okay, no problem.
Yeah.
I guess I'll pretend that I'm a neurosurgeon.
Who is now organizing the TV? Is it still Ica behind that or not?
I'm sorry?
Who is now the main organizer of TV? Yourself?
Yeah, I am. And Juha wants to do this.
I see.
Yeah, he wanted to do it, and I'm glad he finally is getting a way to reach the Chinese neurosurgical community.
So it's going on some China platform or not?
Yeah, he's reaching a lot of China neurosurgeons. This is also going on WeChat, and going on a big website in China.
I see.
So it gets between 5,000 and 10,000 neurosurgeons. So he's reaching who he wants to reach. Hello, Juha, are you there? He's here. He's probably getting set up. So how you been, Vlad? I see you speaking everywhere.
I do.
That's good.
Which is fun.
Yeah. Well, to me, I love it. I'm trying not to do too much.
Yeah. Well, you should do some surgeries by now. You should start practicing.
Start what?
Practicing. You have learned everything by now.
Yeah. Well, hey, we're gonna. Do you mind if we play the game? Has Vlad read this book? We won't do it if you don't want to. That's okay.
Good.
So, what is on your bedside reading now?
Some novel. You know, I've got time when I go to bed for half an hour reading, so I don't really know what is the name of the novel. I just read it for a while.
Oh, okay.
And then something about the development of human species.
Okay.
Which is
by
some French guy, you know, a little out of the mainstream.
Well, you kind of have to I have to force myself to read because I stop reading when I use a computer.
That's true.
I get lazy.
You see behind me, the house is full of books.
Yeah.
And when we go to bed with Eva, we both have readers. You know, we do not open a book at all, or no, almost not at all.
Yeah. Okay. Yeah. I used to read I had a bookstore called Kafka's. I told you, right?
Right, you did.
Yeah, it was a used bookstore, which is a wonderful hobby. It is. If you can have a store pay for itself and you hang around. I had it here in Miami Beach, and there's not many people that read here in Florida.
No, that's true. That's true.
Even without the pandemic.
Yeah.
So that most of the business was Europeans coming to Miami.
It is. It is. Juha, hello.
Hello, Vlad. Hello, John.
Hey, Juha, how you doing?
I'm fine.
Good.
Oh, good. So you got
nice that you are here, Vlad. Welcome.
Thank you.
Hello, John. How are you?
Manuel, you know Juha, right? Manuel?
Yes. I have the honor to talk to Professor before.
Okay. Yeah, Manuel's from Russia, from Moscow.
Yeah.
The typical Russian guy.
Second year. What year are you, Manuel?
I am just finished the second year of my residence program.
Okay. Welcome.
Hello, Professor Juha. How are you?
Hello, hello, I'm fine. I'm fine. Welcome, Manuel.
Hello.
Hello.
Hello, Harshad.
Yeah, this is Dr. Parekh from Mumbai, India.
Hello.
Welcome.
Hugo is here.
Hello, Dr. Andrade.
Hello, how are you?
Good. How you doing?
Good, thank you.
So
Professor?
you were in Finland and then you came to China.
No. I was in Finland and then I work in Toronto and then in Germany and then to China.
And he's speaking so fluent English, difficult to understand.
Now, you like Juha, you didn't know Chinese before you came there, right?
No.
No, not one word.
I still don't know.
Still?
Yeah.
You can get by on a little bit of English, a little bit of Chinese?
Yeah, normally with the mobile phones we can use translation and that works.
Translation in real time?
Yeah.
Hello, hello, Professor Leonard.
Hello, how you doing?
Hello, Jijuan.
I'm fine.
You got a haircut.
Hello,
Okay, so you sent it to the major Chinese neurosurgery groups, Siwan?
yeah, I sent some, but I don't know so many
Oh, yeah.
important groups.
Well, we learn little by little. We learn.
Subin is here, so he's taking care.
Oh,
Hi.
Hello.
Hi.
How'd you get in?
Hello, Professor Juha. Hello, John.
How you doing, Ben?
Hi. Fine. Hi. Hello, Igor.
Hello.
Okay, I guess you're going to determine the order, right?
I will speak first, then Hugo, and then Subin, and then Luis.
Louis, okay.
Finishing. Is that okay?
Sure. Now, you say the endovascular people want to speak next week, maybe?
Yeah, the younger guys at the Henan Provincial People's Hospitals, they speak well English, and so they will join. So they needed some time. They couldn't join today, but next week. And
well, they can have their own. Okay, well, they can have another webcast if they want. So
let's begin so that they join us, and then
okay, we'll see.
Sure. Yeah. Of course, here are extremely high number of endovascular procedures. We have more than 1,000 aneurysms a year and 500 bypasses, and they are doing around 10,000 angiographies a year. So they have a huge experience. So they should come and tell.
That's the endovascular department of Henan. Henan.
It's extremely strong. Extremely strong.
Really? Okay. Very good. Very good. Okay. Let me excuse me for a minute. I'm going to do some last minute promotion.
Very few people. Yeah.
小亮，今天会议是8点开始，时间改了一下，你要加入。
Did you advertise to be for the Chinese neurosurgeons?
Yes.
Good.
Now, you know, the cumulated audience for our series is more than 20,000.
Oh my goodness. Oh my
Yeah.
goodness. Good number, yeah. I hope it helps now when it is 1 hour earlier because after dinner time,
Yeah,
so
yeah,
they can
yeah,
find more easy.
You know, Juha, if you want, we could change it to 7 if that's even better for you next week.
No. 7 is too early.
8's good.
Yeah,
8's good.
8 is good. Yeah.
Okay.
It's good, yeah, because I think usually the Chinese have a dinner and
Yeah.
time, and then they can join 8 o'clock.
Yeah. Actually, I just come back to home.
Okay.
From working. Yeah.
You're coming right from the hospital now, Ben?
Yeah.
Oh, okay.
I just come back from hospital.
Are you home or at the hospital?
Yeah. I'm in home.
Oh, okay.
Yeah.
What is your question? Subin is home at hospital or are living close to the hospital or inside the hospital?
Now I'm in my home.
Yeah. Is it far away?
Mm-hmm.
Is it far away?
Yeah, it's when I go to East or West campus, normally it's around 21 or 22 kilometers from my home.
And in time, you are driving?
Time is around 40 minutes driving.
Okay, 1 minute. Start. Okay, you ready, Juha? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have Juha's Neurosurgery Grand Rounds. I'll turn it right over to Juha. Good day, Juha. It's all yours.
Thank you very much, John. Ni hao. Good evening, everybody. So I will speak about surgery of PCAM, internal carotid artery aneurysms. In the regular speaking, we speak many times of PCAM aneurysms, but it is not true. They are originating from internal carotid artery. But we speak usually about PCAM aneurysms. The true PCAM aneurysms are rare. We come in the next lectures to that. So I'm working in China now at Henan Provincial People's Hospital, and I will speak about surgery of PCAM, internal carotid artery aneurysms. So this is the background for this lecture. I have been working in Finland in 2 cities, Kuopio, Eastern Finland, 17 years, and I was chairman in Helsinki, 18 years. In these centers, we formed a very good, profound databases on cerebral aneurysms. So altogether, there are more than 17,000 patients with more than 22,000 aneurysms with good follow-up and clinical data. And in this series, there are more than 4,000 internal carotid artery aneurysms. I checked the data of first angiography in Finland. It is even earlier. It is 1936 when first cerebral angiography was done, 9 years after Monet's introduction of the method. So how it was in earlier times, this is angiography. Puncture. I have done also this when I was resident with it in trauma cases. I have done maybe 200 angiographies with direct puncture. And how was it in earlier times to treat the aneurysms? Very difficult. You used silk ligature and primitive clips, Oliver-Krona clips, to take the base of the aneurysms. This is a large MCA aneurysm. So it is usually said, what are the PCAM aneurysms? These are aneurysms of internal carotid artery in close proximity of PCAM artery. This is the Finnish Helsinki-Kuopio database, site of the aneurysms. So most common aneurysm is middle cerebral artery aneurysms, and internal carotid artery aneurysms form 20%, so more than 4,000 patients in this series. PCAM aneurysms are many times called easy aneurysms. I did my first neurosurgery in July 1976. It went well with high-fetch clip. I was assisted by my mentor, late Seppo Pakarinen, in this operation. It went very well. But this week, on Tuesday, I operated PCAM aneurysm, easy aneurysm, had intraoperative rupture, which I could manage, and the patient is doing well, but it shows that these aneurysms might be difficult to handle. Maybe it is the attitude. You think they are easy aneurysms, and then you will have difficulties. And this is very important. The attitude of the surgery. You don't have any easy aneurysms. You have to be ready to handle everything. Next week, I will show the Tuesday case. We have a video of what happened in the operation. So PCAM aneurysms are generally above the skull base. They have surprising high management, morbidity, and mortality when you make careful checkup of the cases and long-term follow-up. And what is the reason for complications? It is usually occlusion of the posterior communicating artery. If it is larger one, so the patient might have infarctions, and also the perforators of the PCAM are important. So these are the usual causes of complications in the patients. How to diagnose PCAM aneurysms? We used good quality CT angio for open microsurgery because you have to see the skull base. We have to see the relation of the skull base and aneurysms, because if the aneurysm PCAM ICA aneurysm is located close to the skull base, then it might be very difficult to treat. For open microsurgery, DSA pictures are floating in heaven because you don't see any skull base. Of course, they are good for endovascular surgery, but not good for open microsurgery. You have to see the skull base. Good quality CT angio is extremely important. As mentioned, we have to see the relation of the skull base and aneurysm. Careful preoperative study, you can do it rather quickly when you have devotion and skills to do the CT angiography. We could manage very well with CT angiography. DSA angiography DSA was very seldom done. When treating these aneurysms, only in very proximal PCAM aneurysms, you have to do anterior clinoidectomy. And then sometimes if the aneurysm is large, you have to think about proximal control. Also, seldom you can use the cervical carotid artery, or you can use the balloon. I had 3 carotid dissections with balloon, so I have given that up, and my usual proximal control is intracavernosous carotid artery because it has very seldom atherosclerosis, and of course you can come there only with clinoidectomy. There are different surgeries in PCAM ICA aneurysms. You have elective, unruptured, then you have acute, ruptured, and emergency. Large intracerebral hematoma is usually located in temporal lobe, and if the patient is poor condition, you can save patient's life by emergency surgery. And then you have advanced, well-planned approaches in the cases of large, giant, or fusiform aneurysms. Planning, how is the patient, what is the patient grade? Usually a World Federation grading is now used. We used earlier Hunt and Hess, and Dr. Drake used Waterer grading. I have been using that also when studying Dr. Drake's and PLS cases. All are rather similar. Then the patient age is important. If there is intracerebral hematoma, size of the aneurysm, which type of the aneurysm, ruptured, unruptured, and very important for open microsurgery are if there are calcifications present, because they mean that the clipping is more difficult. I position always myself, the patient, and think when positioning how the aneurysm is directed and modify, tailor a little bit head position to have good angle to clip the aneurysm. And during the surgery, I change the head position frequently. I ask the anesthetic site to lift the head or go down with the head. And of course, I'm using the mouthpiece in the microscope. It means that my angle can be easily changed. And in my videos, that is all the time moving. This is coming from the movements of the microscope with the mouthpiece, which is very useful and makes the surgery by far faster, cutting around 40% of the surgical time. This is the craniotomy I have been using since 80s, lateral supraorbital approach with minimal saving, preparation of the wound for short incision, local anesthetic infiltration with lidocaine and adrenaline, and then I make a single layer flap. It means because the temporal muscle is cut only short, like you will see in the videos, so there is seldom temporal muscle atrophy and never frontal facial branch injury. This is important because this might be cosmetically difficult. When you are dissecting toward the aneurysm, so you creep slowly with forceps and sucker subfrontally. I'm using many times water dissection to separate the frontal lobe from the skull base, and then sub dissection is the best method to dissect the aneurysm, and I use more often than not temporary clips. Here in Henan, in China, there is huge atherosclerosis, and this makes use of temporary clips difficult, and this is one of the big differences to operate on here than in Europe or other places of the world. So the common and heavy atherosclerosis, even in younger patients, makes the surgery by far more difficult. Then in fresh subarachnoid hemorrhage, you have red, angry, swollen brain with good neuroanesthesia. You will change it, slack brain. In surgery, you can open lamina terminalis. You can do also ventriculostomy, which I don't like, because with lamina terminalis opening, you go always to the right place. With ventriculostomy, you might not hit the ventricle and cause some intracerebral bleeding. So I like lamina terminalis opening. I think in the videos we will see how it is. So here is the first video. This video is edited by Johan Shoku Velasquez, my fellow. He made huge work in these 1001 videos, this Cta angio is not so good, but here you see how the aneurysm is broad-based and very thick PCAM was coming from the base of the aneurysm. This one you have to save. This is must here and might be difficult with endovascular means. So here, lateral supraorbital approach, and we are creeping below the subfrontally towards right optic nerve and opening the basal cisterns. CSF is coming and then slowly sucking out to have slack brain to have good view to the aneurysm. And here is sharp dissection with microscissors. I'm using high magnification. And take a look now on the aneurysm. It looked very innocent. It is not. It is not. As very thin places in the aneurysm, it can never rupture, but this would rupture. So I put here, take a curved clip, which is taking the proximal carotid artery, but also the PCAM inside the temporary clip. Both are inside the clip now, the big PCAM, and then we put the distal clip below anterior choroidal artery, and then we have trapped the aneurysm with the golden temporary clips. And now we dissect the aneurysm carefully, taking the small arachnoid bands. And this is pilot clip, rather much opening. This is Sukita Mitsuho clip going there. Looks rather clumsy clip, big in relation to the aneurysm, but opens much and it has plump ending, so it is not so easy to perforate the aneurysm. And now taking the temporary clips out. And here you have to be careful because the clip handles may be stuck to each other, so you have to be very slow and carefully taking out. And now the proximal clip is coming out, and now we begin to dissect the aneurysm. I coagulate down the aneurysm, dissect it. It looks bigger than in the CT angio. It is usually 1 millimeter bigger than in CT angio, and now I coagulate down the aneurysm, dissect it. On the right side is the oculomotor nerve, and then I take the scissors. You see, the scissors are like crocodiles, look big because the magnification is high, and I cut the aneurysm because it is attached to the oculomotor nerve, and work more with the aneurysm. There's no bleeding because the clip is taking the base, and now check the situation and then coagulate down the remnant of the aneurysm here. And here you have to be careful, like you see that when I coagulate, it may stick to the aneurysm base, and now I change the smaller clip or add smaller clip. Yeah, here I leave the original bigger clip in place and check the situation now, and then we make CT angio to be sure that the PCAM, the big PCAM is filling and free, and also its perforators, and this is CT angio after that. Control angio. So next, here we have, I think, a ruptured aneurysm edited by Daniil Kotirov. He's in Israel now, originally Russian. Here's a left ruptured PCAM ICA aneurysm. Where is the aneurysm? Where is the aneurysm? Ruptured aneurysm. Very small aneurysm. Even very small aneurysm rupture. And this is something Isua study was claiming they don't rupture. This is not true. Preparing left side, please note, no shaving of the hair, and only little shaving, and then cutting down, hooks, retracting, one burr hole here. I have done this since I was young neurosurgeon, I didn't understand why you are doing basally the hole and then making 2 cuts with craniotome and then breaking the flap out. And now you see how slack is the brain. Good neuroanesthesia, wonderful neuroanesthesia. Even the brain is red, angry, swollen. So there is enough room. There is subdural hematoma. This happens in PCAM aneurysms, small subdural hematoma. And again, creeping down, going to the optic nerve. This is our landmark, optic nerve. And opening the basal cisterns. Cutting arachnoid fibers here with the microschizos. And now we have the ICA here covered with fresh blood. We usually operated on the first day, even the day of the rupture. And now we see where is the bleeding coming. There's some bleeding now. Yeah, let's take a look. I put the temporary clip proximally. And then I should put the distal clip also, second temporary clip below anterior choroid artery. And then we have the aneurysm base dissecting with micro dissector here now. Now my hand is covering the light, but the pilot clip is going like in the first video in place. It's not taking all the aneurysm because it should be a curved clip here. It should be a curved clip here. Let's see what's happening here. Okay, I take a curved clip here and put it below the first one. There's enough space for that, and then slowly bring the clip into place. This is actually not double clipping technique, but this is more detailed. Then I take the distal temporary clip out and then proximal temporary clip out and take also the first straight clip out. And now it should be okay. Many times I continue, but this should be okay. This should be okay. Now you see that the aneurysm is already empty, ruptured. It is empty. Now we check the situation, and I put one more clip. Now it is what we call double clipping. You have 2 clips besides each others to take all the base of the aneurysm. Then flushing. This is Doppler probe, small Doppler probe to check the flow. And clean water by flushing, and usually adding some papaverine on the place. This is papaverine now going to release the manipulation spasm. And this is the situation after surgery. Closing controls here. So we go to the next case. Again edited by Daniel Kotyrev. Left ruptured PCAM segment aneurysm. This is a larger one now and later than not operated in the first day because there was not so much blood in CT. You cannot see so much blood in CT. So again, you see that there is a fresh subarachnoid hemorrhage anyhow. This is the left supraorbital approach going towards left optic nerve. There's some atherosclerosis, but not so heavy in the carotid artery. Here you see extremely heavy atherosclerosis in China, at least in Henan. Now we check the situation. It was a larger aneurysm. We put the temporary clip again here, proximal temporary clip. And then here I didn't put distal clip. And this is the pilot clip, first clip going there and checking the situation. And what happens now? Bleeding? Yeah. Now something happened. So it is bleeding from the base of the aneurysm. There was some atherosclerosis and the aneurysm broke at the base. Now it's very difficult situation. I have added already temporary clip proximally, and now try to manage the situation. One clip, second below that. This is double clipping method. The first clip is pushing the second clip down. And now let's see what happens. Is it okay? And I travel with the clips. I go again with the clip below the first one to take the bleeding site at the base of the aneurysm. And now took the temporary clip out. But it seems that it is still bleeding. Yeah, it's still bleeding. It looks very brutal, very difficult situation. So now I coagulate down the aneurysm, and can we handle that? Yeah, I coagulated down the aneurysm and now travel with the clips proximally, more and more proximally, because the rupture was at the base. And take the first clip out, the distal clip out, and check the situation. And still bleeding, still bleeding. So I coagulate down base of the aneurysm to have the bleeding side under control, and then put the clip there, and then take the temporary clip out and cut the aneurysm, so to see all the base. And then I have the remnant of the aneurysm here, and I coagulate it totally down and move the clip and put one more clip. This is now should be the final position of the clips. I'm playing now. What is? Yeah, I took the clip out and coagulated more, and now seems to be under control. Sometimes, if you play too long, you might have difficulties. Here it looks that I am not happy with the clips, but now it is the final position. We are doing ICG, and the rupture site was at the base of the aneurysm caused by our manipulation, and also very difficult to handle. These are the post-operative angios, looking good, and the patient was doing good recovery, but very critical situation in the operation that could be handled. Next case. This is a right unruptured PCAM segment ICA aneurysm. Rather old patient, 74 years old patient. CT angiographies, and here is the operation: supine position, lateral supraorbital approach, right side, again creeping down to the right optic nerve, and then there's some bleeding. When you retract here, you might have from the veins at the temporal pole, you might have bleedings, and they might be difficult to stop. Calculating here arachnoid and then checking the situation with dissector about PCAM. And this is, where is the aneurysm? Where is the aneurysm? Checking for the aneurysm. This has very special direction. This aneurysm is directed posteriorly. It is more seldom. Usually they are directed laterally when towards. And this is the final clip now. Different solution. So I took a ring clip, and the ring clip is taking the base of the aneurysm below carotid artery. And here you have to be very careful. Of course, this clip might take also the PCAM, so you have to check it, and we are checking it now so that the PCAM remains free from the clip and only the base of the aneurysm is taken. And this is the very useful small Doppler probe to check the flow, because you can repeat it all the time. ICG angio you cannot do so many times, it takes more time. So this is very useful here. So this is part of the aneurysm. Here is part, I couldn't show papaverine to release the spasm from the manipulation, and then situation after surgery, and then comes closing in layers, clean water by flushing, and these are the control angios which show the ring clip, L-form ring clip in place, and these are some more controls to see that the whole aneurysm has been taken. Next case. This left ruptured PCAM ICA aneurysm. You see the heavy bleeding in CT, and this is the CT angio, rather large aneurysm, and with pooch, secondary pooch at the end, showing where is the rupture site. Lateral supraorbital approach, one layer flap, opening the dura. In 10 minutes, I'm intradural with this simple flap. This is the right optic nerve. And here I open the lamina terminalis to get space and dissect here the sylvian fissure, because it is a large aneurysm. So it is good to open the proximal sylvian fissure here. This is Kamiyama's kissos were there in the picture, and are now dissecting the sylvian fissure open. This is water dissection to clean the field. And you see there's a lot of blood, fresh subarachnoid hemorrhage. And now we are seeing, after flushing and cleaning the field, we see the aneurysm. There's some bleeding. And now again, flushing, cleaning the field. And now we should have a temporary clip. Yeah, it's going here. The proximal carotid temporary clip. And now with the microdissector, cleaning the field for the second temporary clip below anterior carotid artery. And now you see the aneurysm is slack, but it was rather large. So I put the clip here on the base of the aneurysm. It was a ring clip because it is a large aneurysm, and a straight clip after that, and take the distal temporary clip out, cleaning the field, checking how is the aneurysm. Is the aneurysm slack, totally occluded? No, it was not. So I put once more the temporary clips, and I have to change the clips now. And this is now again some bleeding. I take the clips out, and I should take a, I take a straight clip and put it oblique, so to take all the base of the aneurysm. And here, temporary clips removed. There is some, now I coagulate the aneurysm and put once more temporary clips. Why? I want to advance and change the position of the clip, and there remains some small part of the aneurysm remains unclipped. I would put here a small clip, and I put it here, so to take this part also. And now it should be okay. Don't play anymore. Don't play anymore. Yeah, checking the situation now, and what he's playing. What? Yeah, change the position of the small clip, and now Doppler probe, checking if there is flow in the aneurysm, and again changing. Now, this surgeon is crazy. He should stop now with the clips. Okay, now coagulating the aneurysm down. And now papaverine added to release the manipulation spasm. Now this is post-operative CT control, several clips, 2 or 3 clips there, and the patient recovered well. Next video. This is edited by Juha, who was responsible for the 1001 collection of the videos. So these are CT angios and very small looking aneurysm here. Again, 4 mm maximally, left lateral supraorbital approach, short incision, 1 layer incision, and now dura open here, and we go for the aneurysm. Left optic nerve, sub-dissection of the basal systems, opening the proximal Sylvian fissure. This is good sometimes to do in PCAM, ICA aneurysms, if they are higher located. So dissection with scissors here, and now we soon can see the aneurysm, cut the arachnoid around. Freeing the proximal carotid, that small perforator, and now you see the left anterior choroidal artery is above the aneurysm. This must be saved. If you occlude anterior choroid artery, then the patient has extremely severe deficit. So you have to take utmost care to preserve anterior choroidal artery, and it is so close to the aneurysm, so you have to be very careful not to occlude that. This temporary clip is going below anterior choroid artery, so now the aneurysm is trapped. Thin wall. I used to coagulate the aneurysm down and then put the clip here, like gentle handling, so aneurysm is going down. And then putting a clip here. It is written here, pilot clip. I take the temporary clips out, and I think I should add 1 more clip there. proximal temporary clip coming out, and then I should add one more clip here. I'm checking the situation. Yeah, one more clip is going there. Double clipping, taking the base of the aneurysm, and I leave both clips there because the first distal clip, oh, I'm taking it out. Oh, I should leave it. I should leave it. What I'm doing. I was just telling that the first clip is pressing the second one down. Okay, now I'm playing. Now I'm playing. So there's remnant of the aneurysm, and I put proximal temporary clip and coagulate more down, kill the aneurysm totally. And now I should, there's no clip now in the aneurysm. I'm making the IC angiography without clip. This looks not nice, but I have a good flow in operation, and then now I should draw the aneurysm remnant inside with the small forceps, or then put second clip there. This is the situation now. Yeah, papaverine, and this is the postoperative control. So I think there's one more video for some special reasons. It's right unruptured PCAM, ICA aneurysm. Main part of the aneurysm we operate are small, even of the ruptured aneurysms. Here, in this case, it has been coiled. It has been coiled, so there's compaction of the coils, and that's why surgery was done. Coils were compacted at the end of the aneurysm. Here's something wrong in the video editing. It looks like I'm doing twice the skin incision. So we go down. This right optic nerve. And sharp dissection. Downstairs with the big looking microschissos. Using very high magnification, the highest of the microscope, so to see better. And then we see the aneurysm, and we see also the coils at the end of the aneurysm. So it looks like that when the coils are inside. If they have been longer time, so they may be involved in the aneurysm wall, and they are more difficult to do here. So I'm checking the situation. I put temporary clip here, proximal carotid, and put the pilot clip on the base of the aneurysm because there is enough base to put the clip because the coils have been compacted very much. Take the temporary clip out and now begin to check the situation. Here's IC angiography after clipping. And if you can manage without opening the aneurysm and taking the coils out, it's good. If there's enough space here, I open the aneurysm and manipulate, cut the coils and take part of them out. This is of course not necessary. Then put a second clip here to take the base totally. Check the situation. And this is how the final situation is. So cleaning the field, and these are controls with a lot of artifacts here with the clips and coils. So these were the videos. Once more, become ICA aneurysms. They are not easy aneurysms. There's a lot of discussion, so-called cocktail party discussion. These are easy aneurysms. How fast can I do this aneurysm? But it is very important to note that at least those very proximal aneurysms might be very dangerous and difficult to treat, needing scalp removal of the scalp base. So you have to be very careful with them. So finally, I want to say, to be the highest level of neurosurgery, you have to have good skills in surgery and English, because the English is the language of the neurosurgery, and to report your experience, it happens in English. So you have to have skills in scientific writing and English, and this is very important. And finally, don't shave the beautiful Chinese hair, like here. Females have beautiful hair, and you should do focused minimal invasive haircut, because the present standard is to take all the hair out, and this is not good. So you can do, like in this 10-year-old girl, parietal AVM, you can save the hair, and the patient is extremely happy to have beautiful hair when going home. This is what I think important and could be changed here in China quickly when changing the attitude. And to speak about the treatment modality, there is a lot of speaking that to open the head is dangerous. It is especially in China. You have the old tradition to think that to open the head is dangerous. It is not dangerous. It is our profession. Those who say that to open the head is dangerous, they should not call themselves neurosurgeons. And those who are opening the head in a dangerous way should stop their activities, do something else, endovascular or neurology or psychiatry, not neurosurgery. So this is good team here in Henan. Good team is very important. No one can do surgery alone. So I thank you very much, JJ. This was my lecture here. Thank you.
Okay, Juha, thank you very much. Would you like to take questions now, Juha?
For me, it's good. For me, it's good. We take after Hugo.
Okay. So you want to introduce Hugo, please, Juha?
Yeah, Hugo Andrade is my good friend. He came as a very young medical doctor to Helsinki, and then joined us later as a fellow and made his PhD on contralateral approach in cerebral aneurysms. After Helsinki, he was doing his fellowship in Toronto, and after that has been working in Mannheim, Germany, and after that he joined me in China. And this has good skills and good scientific writing, and the drawback has been now that he has been locked down in Germany a long time. So he's eager to begin surgeries. I hope China will open soon. Welcome, Hugo.
Thank you, Professor. Greetings, everyone, and thank you, Professor John and Binshu, for organizing and translating all these talks. So as Professor said, I'm going to talk about contralateral approach and aneurysms. I'm just going to share this now. Can you see my talk now?
Yes.
Hello? Yeah, okay. So today I'm going to talk about Contrata approach to anterior circulation aneurysms. A little bit of my background, as Professor mentioned, I'm from Venezuela, where I did my medical studies and neurosurgical training. And then I had been all over the world. So now I'm currently working in Tenjo with Professor, and also I'm part of the neurosurgical research lab in the University of Mannheim. So I had nothing to disclose. So if we remember a little bit of the history of intracranial aneurysms, we remember one of the first aneurysms that was done by Dandy in 1917. And it was done through this big approach that it has a frontotemporal, zygomatic and orbital approach, and it was called omega sign approach. And then we had seen since that time to late 70s, where Professor Yazagil introduced the Terona approach. That was a big advancement in intracranial aneurysm surgery, because he used a center craniotomy that was centered on the pterion, and also he used the natural pathway of the brain, that it was a cistern, and also improved illumination because of the microscope use and also microsurgical instruments. However, in the last 30 to 20 years, we have seen a tendency for what we call minimal invasive like neurosurgery for cerebral aneurysms. And it's just modifications of the Terona approach, and they named, you can have it supraorbital approach, lateral supraorbital approach, or mini-Terona approach. And the idea is just to improve cases, improve outcome, and also shorten the hospital stay and recovery for the patients. So how can we achieve minimal invasive surgery? First of all, with smaller craniotomies, we have seen that, or either we can perform fewer craniotomies, but also we can achieve minimal invasiveness with endovascular techniques or endoscopic endonasal techniques, or combined techniques, open surgery plus endoscopic, in order to have better trajectories and working angles. So if we see here, we've seen how has been the evolution of the microsurgical approaches. It's just examples of the Terona approaches, heat modification to the supraorbital approach, mini-Terona approach, and lateral supraorbital approach. So if we have pathologies in one side, we can approach to this side. But also, what happened when we have one aneurysm on the left side? This is just a 3D CTA. When just one aneurysm on the left side, we can approach that from the left side approach. We can use a LSO, a mini-Terona approach, Terona approach. But we have other two aneurysms on the right side, and either we do bilateral craniotomies, or we can go from one side to the other side, and this is what we call contralateral approach. So also we know that intracranial aneurysm carriers, they have multiple aneurysms, around 30% of them. And the most frequent locations are middle cerebral artery, Ica bifurcation, ophthalmic artery, and PCOM. So in those cases, we can justify using either one approach compared to the other one. So either in these cases with multiple aneurysms, we can offer multiple endovascular treatment and secure all the aneurysms in the same time or the same session or different sessions. And you can see here how the aneurysm, how the patient has 5 coilings. But also, we could offer to the patient that we do 2 craniotomies or 2 mini craniotomies, as published before by Murayama, or also how we had done before, and then we're securing both aneurysms. So the Contrata approach, what it says, we open one side of the brain or the skull, and then we go from this side to the other side. And you can see here, we treat this one, and then we go to the other side. And this, what are we causing with this? We spare a second craniotomy and all the risks related to it. We improve the cosmesis, we shorten the hospital length, and it's cheaper for the patients because we're sparing a second surgery. So if we talk already about what are the frequent locations for the aneurysms, and we know that ophthalmic aneurysms, parclinal aneurysms are frequently bilaterally, also Ica bifurcation, posterior communicating, and middle cerebral artery. So if we see here, normally the parclinal aneurysms are located medial or lateral. And when we approach from the ipsilateral side, we had to perform a anterior clinoidectomy, dissection of the distal dural ring, and also to achieve control. But what happened when we had this on the medial side? Is it better to come from the other side and in between the both optic nerves. So we spare the need to do an anterior clinoidectomy. So we decrease the risk of complications around the optic nerve also too, and also due to the vasovasorin around the internal carotid artery. So one of the first paper regarding contralateral approach for ICA ophthalmic aneurysms, we measure, so normally the route is this way. We go through the interactive route, and what is important is the distance between the both optic nerves and the distance between the chiasma and the planum sphenoidale. Because this was allowed you or give you the space, enough space to go to the other side. So we measured that on MRI, and also we studied what are the characteristics of the aneurysms and what is the best option for them. So we know that, as the professor mentioned too, 3D Cta reconstruction is one of the main things for us to decide the contralateral approach, because we can mimic how is the surgical field is going to look, and also how is we're going to see the aneurysm. So here we can see this picture. So you can see if you approach this aneurysm from the ipsilateral side, we had to perform a clinoidectomy here and then expose the aneurysm, and it will be under the optic nerve. But if it comes from the other side, if we come from the left side, you see the trajectory is direct trajectory, and we can see the aneurysm neck in front of us. So this is one example of the lateral supraorbital approach, clipping of the ICA ophthalmic aneurysm. This was the same aneurysm that we saw previously. This is the right optic nerve, the left optic nerve here. You see removal of the arachnoid adhesion. This is the route that we go, this is the interactive route. And you see the contralateral internal carotid artery, the right optic nerve, and you can see that we see the ophthalmic artery is just here, and we see the neck of the aneurysm. So it's just releasing the adhesions. Yeah, it has one of the disadvantages from this one is that we don't have proximal control of the aneurysm, because it's difficult to achieve that. But in that case, we publish a temporary transient cardiac arrest during adenosine, that you can have a slack aneurysm and just place a clip. So it's a very straightforward clip with some bleeding. And then you see straight clip, then this double clipping technique here, and then just ICG to see the flow into the parent artery and the ophthalmic artery. So how is the view from the contralateral approach? This is another example. You can see this is ipsilateral right side aneurysm, it was clipped. Then the contralateral side ophthalmic too, it was clipped through the interactive way, and then you can see the aneurysm also clipped in the same way that previously described. So what are the characteristics for the aneurysms? So in our study, we identified that normally the aneurysms that are approached through the contralateral side are unruptured aneurysms. They have saccular shape and they're small in size. Also, the projection, it was supermedial, and in our collection of patients, we had 30 cases. They have a left side predominance. And I think maybe it was because the professor was a right side surgeon, so it was better for him to go from the contralateral side. So what are the radiological criteria for contralateral approach? In our study, we determined that it was a small aneurysm, less than 10 millimeters in diameter and also in length. Simple configuration, because we know if we have a complex configuration, we cannot do it from the contralateral approach because it's deep and the surgical corridor is narrow, so it's difficult to maneuver during this surgery. Also, unruptured aneurysms, because you wouldn't approach a ruptured aneurysm through the contralateral side. You don't have any proximal control in that case. And in this case, medial superior medial projection for ophthalmic aneurysm is the most physical one. Lateral, you should do through a ipsilateral approach. And what is important is to have a preoperative 3D CTA images, because you can see the skull base landmarks and then the specific distance and measurements. As I mentioned before, in our study, we measure the distances between the optic nerves and the prechiasmatic cistern, and we identify a median of 5.7 or 6 millimeters, and a median between the both optic nerves in 10 millimeters. So what is the outcome? We know after surgery through a contralateral approach, there's a chance of 3% visual deficit is because of manipulation of the optic nerve. But however, it has been good outcomes in 93% of the patient, and it does not increase the mortality or the morbidity of the surgical approach. This is proven in our publication. So if we continue following the bilateral trajectories, we know Ica bifurcation also is possible. Let me see if I can remove this.
Yeah, you want to remove those lines?
I really don't know what it is.
Yeah, I think you have to do it somehow. I'm not sure. Does anybody know how we get rid of those red lines? From this is going to the community, but I guess nobody knows.
Yeah. All right. Let me see. I can start it again if it works.
Yeah. Well, whatever. If it's not too distracting, that's fine.
Oh,
no problem.
Don't bother.
It looks good.
Yeah, very nice looking artist.
Oh, okay. There you go. There you go.
All right. Thank you.
Yep.
So if we continue with the Ica bifurcations, you can see here, this is just bilateral Ica bifurcation aneurysm, one complex shape and the other one was a smaller shape. So the left side was the most complex one. That will be the one will be done by ipsilateral approach, and then the other one, it will be done by contralateral approach. And the good thing with this location of the aneurysm is that you have the contralateral approach in a tangential view. So it's better for you when you go for surgery. So this is just demonstrating, again, subfrontal retraction. This is opening of the proximal cilium fissure just to expose the Ica bifurcation aneurysm. This is proximal control here, left internal carotid artery, left optic nerve. You can see here proximal control, then A1, also proximal control, temporary clipping, and then just the clipping of the aneurysm, just coagulating down, then final clipping, and ICG. Then just going to the other side, you can see here interoptic root, left or the right side optic nerve, arachnoid adhesions. You see here, the A1 was there. Now it's coming to the right ICA here. Then you see the adhesions here, arachnoid adhesions here. And then you see the aneurysm is just coming tangential to the view and is projecting anteriorly. So the good thing with this location is like the perforators are behind you. So you can put the aneurysm across the clipping line. So the aneurysm, the clipping will be placed in this direction. So you can have easily temporary clip because your ICA is there. See the aneurysm here, and then you can apply your clip here. You see, you just apply the clip and the clipping line following the distribution of the flow. And then there's less danger to occlude the perforators from the posterior side of the ICA. This is just manipulation, checking that the aneurysm is completely occluded, coagulated down. just checking that you don't include any other perforators in your blades in the posterior region here. That it could be one of the problems if you approach these aneurysms in the ipsilateral side. And this was just to mobilize the clip and also to put the double clipping technique. I think Professor was not very satisfied with the clipping. And those are the steps. Again, just checking the flow and then placing small clip on this dog ear here, and then just running ICG again just to see the flow again. There was no occlusion. The same again, you can see how the trajectory goes lateral now. And then you see the postoperative CTA. So what we can say, we have a great view and angle from these aneurysms. Also, the aneurysm lies above the optic apparatus, and also the perforators lie posteriorly, and also proximal control is visible in these regions. Then if we continue about contralateral MCA clipping, and this may be one of the ones that is favored in this area of the endovascular, because MCA aneurysms are treated better by surgical conditions. So if we can spare a second craniotomy to the patient, then why not to provide it? So we collected around 81, it was 51 patients in our series from until 2015. And so we divided only considered bilateral MCA aneurysms, and we divided between two groups. The group one was only the Contrata approach aneurysms, and group two bilateral craniotomies. And we can see among them, we did 9 patients with SAH. This was coming from the ipsilateral approach, and all the 29 was without SAH or on rupture aneurysms. So what were the characteristics? So we wanted to do a similar to the ophthalmic artery. You just wanted to measure what are the radiological parameters that we could follow, that we could favor for a contralateral approach. And then we measure what was the distance from the M1, or the length of the M1, and the length from the A1, and altogether how much was the measurement. So altogether, for us to select an contralateral approach for MCA aneurysm, there needed to be less than 25 millimeters distance between the A1 and M1 together. But not just the distance, we also needed to consider other important parameters. As I mentioned before, the configuration of the aneurysm should be simple. It should not be complex, because when you have a complex aneurysm, you need other strategies. So as you can see here, it was a simple aneurysm on the contralateral side, just saccular aneurysm without calcification, without secondary pouches, and less than the 14 millimeters in size, or better 10 millimeters in size. And you can see this is one of the aneurysms approach through a lateral supraorbital approach from the left side, and Professor clipped both with one craniotomy. But what happened, so I'm just gonna show you a video. How is the dissection? You can see the complex aneurysm here on the left side was treated with the ipsilateral approach, and then the simple aneurysm was treated by the contralateral approach. Just the same steps again. Left side LSO approach, opening the distal Sylvan fissure, just identifying the M1. Just gonna go a little bit faster here. Did you have the aneurysm there? Already have temporary clip on the M1, and then there was some kinking on the M2, and then just a final clip, pulling the aneurysm sac between the forceps, and then just the final clipping. Then removal of the temporary clip, then ICG to prove the patency of the parent artery and then the distal branches, and that there was no kinking in the M2. You can see it here. And now go to the other side of the aneurysm. Just a little bit Surgicel. And just go the same. We have the left optic nerve on this side, then removal of the, or cutting the arachnoid adhesions here. We have the right side optic nerve, just opening widely. Sometimes you have to dissect a little bit more of the sylvian fissure to give you enough space and retraction from the brain. So opening all the arachnoids. You can see here the right ICA. Here you can see the Ica Bifurcation. And the good thing from the Contrata approach, then dissecting here, is that the M1 or dissection from the sylvian fissure is easier from this side. And you can see the simple aneurysm, there was an M1 aneurysm, was proximal. You can achieve good proximal control. And just to push or to put a straight clip. This case, professor decided to coagulate it down and then just place a mini straight clip. So what is important also is the projection of the aneurysm. What is feasible for the Contrata's approach on the MCA is anterior, superior, and inferior projections. Lateral projection is difficult because then the aneurysm is posterior, so you need complex technique to clip. You can see ICG now. There was still patent the vessel here. And then the other vessels are patent too. So a little bit of papaverine. So just postoperative control. So if we had these aneurysms, for example, this we wouldn't treat from the Contrata approach. You see both are complex, it has calcifications, they have secondary pouches, they're bacon size. So these ones are the indications for ipsilateral approaches. So what are indications for NC aneurysms treated through a contralateral approach? Short M1 segment, less than 20 millimeters in size. Altogether, we prefer to have 25 millimeters in size with A1, M1. They are medial to the lumen insulae, and the projection anterior, inferior, or medially or superior to. Small or medium aneurysms in size, saccular aneurysms without secondary pouches, without calcifications, simple aneurysm, and on rupture. And I said a relative contraindication, the presence of brain edema, because you can see in our series, we only have 8 or 9 patients that we treated to the contralateral sides in the presence of a rupture case. Those cases, it's better just to wait 3 months and then do the other aneurysm. So what we can say about the outcomes, our series were between the described literature, good outcomes you can achieve between 83 to 91%. So we had to minimize retraction because one of the problems is that when you go to the MCA, the patients, they have the risk of having olfactory problems, either anosmia or hyposmia. And in our series, it was up to 21% and only 9% has anosmia. However, it's described in the literature that could be 43% too. And that's for, we had to have a wider sylvian fissures exposure. And we also had to carefully select the patients that we're treating. And we wouldn't advise to do a contralateral approach in an experienced surgeon. At least Professor has done the first case when he has done 300 cases of intracranial aneurysms. And this is proven in our series and our studies. So as a conclusion, we can say minimal invasion can be achieved by maximizing clip through one craniotomy, and also contralateral clipping of bilateral aneurysm is safe in careful selected patients. Just to thank my mentors, Professor Hennessy and me, also Dr. Lawton, who provided a few slides on the talk too. And thank you very much.
Okay, thank you very much, Hugo and Juha. Do you want to? Is Juha there? He may have stepped away.
I'm here.
Yeah. Okay, Juha. Do you want to take questions for you and Hugo's talk now?
Yes.
Okay.
It's okay. It's okay.
Okay, very good. Okay, for the panelists, it's open now for questions or comments. Harshard, I know you had a question. Let me start it off by, go ahead, Harshard, are you there? Okay, he asked, if contralateral aneurysm ruptures, then how do you manage as there's no proximal control?
So it depends on the location. We also publish for, in case of ophthalmic artery aneurysms, when you don't have proximal control, you can use adenosine. And the other way is just it's a little bit more complex, but then you have to open the neck in the other side as a prepare. But normally these ones you should treat only on rupture cases, and that you're like completely sure that you can clip it directly.
Okay, very good. Okay, more comments and questions from the panelists?
Hello.
Hey, hi, Victor. Welcome from Mexico.
Hello, how are you, John Bennett? How are you, everybody? Nice lecture, Hugo Andrade. This is really nice. I remember about 20 years ago, I was with Dr. Pernesky, and he used to make these clips in the contralateral side with a small trepano. So have you ever have you done this kind of clipping of aneurysm with a small trepano?
No, normally the approach that we use is the LSO, and I think because Professor Pernesky was used to this supraorbital approach and it's different the view than the LSO.
Yeah.
I don't know if the professor wants to add something.
Yeah, I don't think we should compete in the size of the craniotomies, how small or how small you can do. Dr. Pernesky made always 1 inch. 1 inch craniotomy, he was measuring very carefully, but when doing large or giant aneurysm through this approach, you lose something from the angles you can treat the patient, and I think it is not sports you should do here to compete how small craniotomy you can do, because the patient is paying for that. So craniotomy should be large enough for your skills, large enough for the aneurysm, and large enough to let the instruments inside and the light inside. This is very important. So I think this lateral supraorbital approach is usually 4 centimeters. I think around 4 centimeters in both sides. And if there's a giant aneurysm, I'm doing a bigger opening to have all the angles to be used. So it's not sports. So it is just that you can do everything through the opening.
Thank you, Dr. Juha. Agree with you. Thank you, Dr. Hugo. Nice lecture.
Thank you.
Okay, thank you, Vic, for the question. Okay, more comments and questions from the panelists, please. Silence.
No question, just John, to say thanks to Professor for the lecture. Vascular surgery is very hard issue and the learning curve is very big. Every time more lecture I take, I say I need to take more and more and read more and more.
Very good. Manuals from Russia, 2nd year medical neurosurgery resident. Okay, more comments or questions for either Hugo's talk or Juha's talk.
There's a question about temporary clipping.
Yes, could you go ahead, Hugh, take that question, please.
I think it depends. Normally for us, I think 5 to 10 minutes is what we use for temporary clipping. And I don't know, Professor can say, I mean, that had been a long time with you together. And so that's our rule.
Okay, Monica Lem asks, what is your experience with PCOM, bilateral PCOM?
So the problem with the PCOM is that they're in relationship to the octave nerve, and normally it depends on the location of the chiasma, and those are the ones who have worse outcome among the bilateral ones because of the position. That's what we analyze in our series in Helsinki.
Mm-hmm. Okay, very good. What is the time limit to use for temporary clipping, or do you use any neuroprotective agents?
My principle is that with temporary clips, I do the job well. I don't want to listen that somebody saying 1 minute, 2 minutes, 3 minutes. Usually it is going below 5 minutes and it is safe. I always think about there are basilar artery thrombosis or middle cerebral artery thrombosis. They come late to the hospital and when relieved, the patients have good outcome. So I put my temporary clip, but before putting the temporary clip, I prepare well. I have temporary clips ready. The scrub nurse knows which clips I need. So everything will be very fast. And psychologically, I think that somebody is running a mile below 4 minutes, or some Africans are running 5 kilometers below 13 minutes. So I should have a lot of time to do. So I don't try to be very fast, don't become nervous, just do my job and then take the temporary clips and listen how long they were in place, and usually it is less than 5 minutes. I analyzed Dr. Drake and Pierle's basilar artery occlusions. So below 5 minutes was always safe. And below, when repeated clipping, below 15 minutes, always safe. But basilar artery is, of course, different because it has posterior communicating arteries as compared to middle cerebral artery, which has its end artery. So they are different, but 5 minutes is always safe. This is the final answer.
Okay, very good. More comments or questions from the panelists? You can text a question. Okay, here's a question from Joseph Navarro. For PCOM aneurysms, is LSO enough, or do you also consider doing a mini perional, especially for PCOM aneurysms that are pointing more medial?
I have not done LSO is enough. These PCOM aneurysms, in some MCA aneurysms, which are projecting more temporarily, you have to make advanced approach, take a little bit temporal bone away, but usually it is enough. Usually it is enough. I don't remember a case PCOM which I should have opened by far more, because the angle depends. If you move the microscope with the mouse switch, so you can manipulate a lot.
Okay, very good. I think we can move on to Dr. Ben. Oh, unless is there another question?
I have one.
Go ahead. Go ahead. Hi, Sunil. How you doing?
Yes, good. Hello, Professor. I was asking, like, what is the dose of piperacillin like you use for the vessel spasm? And do you use this piperacillin as an IV or like in the surface of the vessels you use?
Now you ask something difficult. I just asked the nurse to give me papaverine, and she's soaking the surgical patty in papaverine. I cannot say. I should ask carefully. But it's regular papaverine. We put the surgical inside and then put on the artery. I cannot say which is the concentration.
And one more thing, like, do you still use papaverine in China?
Excuse me?
Do you use papaverine in China also?
I didn't catch. In China, I don't have adenosine. I don't have papaverine.
Thank you, Professor.
Okay, there's a question from Duong Trung Kien. For oculomotor nerve palsy due to PCOM, do you open the aneurysm after clipping?
If the patient has oculomotor palsy because of PCOM aneurysm?
Yes.
Yeah, this is it is good to put the clip and then open the aneurysm. Then you relieve the pressure on the oculomotor nerve. I think with the surgery you have better results than by endovascular treatment of PCOMs with oculomotor palsy. This is one indication for open microsurgery. So you clip the aneurysm and then open the aneurysm and even cut the aneurysm. But you should not manipulate so that you try to take the end of the aneurysm because it is attached to the oculomotor nerve. So you can cut the aneurysm and so leave this part on the oculomotor nerve. But the outcome is very, very good in these cases. If you operate within 1 week, we published in 90s, we published a series from Eastern Finland, Kuopio by Sirpa Leivo on these cases. And they had very good outcome if you operate it within 1 week, and the best one within 3 days.
Okay, Harshad Parekh from Mumbai, India asks, any role of wrapping of the aneurysm?
No, I don't remember a case I should have wrapped any aneurysm. So all have been treated by clipping direct surgery. And of course, if there is a small part of the aneurysm remains weak looking, I put the patty and glue on that, but this is not real wrapping. So I think it should not be done. If you have wrapping is very unsure method to secure the aneurysm, and I wouldn't do it anymore nowadays.
Okay. Any last comments, questions from the panelists before we move on? Okay, very good. So let's move on to Dr. Bin. Can you introduce him, Juha, please? Dr. Bin?
Yeah. Dr. Subin is working at Huashan Hospital, Shanghai. He's doing mainly bypass surgery, but also neurosurgery, and he has also endovascular specialty, so he is very widely trained. He has very effective team to do bypass surgery. So for example, last week, not this week, but last week, I was told he was doing 30 bypasses and in 1 day, 13 bypasses. So it means, of course, traveling in different rooms, but extremely effective team, and his personal experience in bypasses is more than 7,000. So this is one figure no one else in the world can achieve, and he has very special techniques developed when he was working in hand surgery. So has developed extreme skills both in organizing the bypass operations, but also in the doing the real bypasses or anastomosis bypasses. So I think this is enough. He's the world champion in bypasses, and it is very difficult really to beat his experience. And he's a young man, so he will achieve a lot in future.
Thank you. Thank you, Professor Juha. So today my topic is the basics of bypass surgery, part 1. I will introduce the end-to-end anastomosis. So end-to-end anastomosis normally used in the MCA anastomosis, like this case. This is a partial thrombosed long segment MCA aneurysm. So I resect the MCA aneurysm, but we still got enough length of the vessel to do the direct anastomosis. So I just cut the aneurysm and made the end-to-end anastomosis. So this is the final result. You can see the vessel was patent and the stoma was quite good. But more frequently, the end-to-end anastomosis was used in STA because when we do the craniotomy, sometimes unexperienced assistant may cut off the STA accidentally. Sometimes, if you use a monopolar or bipolar, you may accidentally coagulate the STA, so the vessel was not patent anymore. Sometimes when we use clipping technique, but sometimes if the vessel, if the aneurysm was ruptured at the neck of the aneurysm, sometimes we have to sacrifice some blood flow for the parent artery. So we may need some flow replacement in the operation. So this time we may need the STA. So we have to harvest the branch from the distal part and then do the end-to-end anastomosis to make the direct bypass. So this is the technique notes. At first, we will cut off the coagulated segment, make sure we anastomose the patent once. Then trim the tonical adventitia of the vessel. Normally, I will cut oblique one to make the circumference more longer. So then made the intima to intima evolution suture. So the needle spacing is 1.5 to 2 times of the vessel wall's thickness, because this is the same vessel. So the thickness of the vessel wall was same. Normally, I use 10-0 suture. So this is a sample video. This segment, you can see it was already coagulated, so it's not patent anymore. So I cut off the segment at this segment. Then expose the vessel cavity. Now it's the vessel cavity is healthy, and then cut off the trim the adventitia, and then left enough space for anastomosis. So then, making the stoma, I cut it in an oblique way. It's not a fish mouth. I cut out the triangle. It's very sleepy of the vessel wall. So don't touch the intima of in the vessel cavity. Methylene brome. This is the heparin saline. Now trim the distal part of the stoma. Cut off the adventitia. So the distal part is already formed, the oblique one. So when I cut the first cutting, it's already in an oblique way. So now the vessel cavity was all patent. Now makes anastomosing. So one side here to another side tore. So in the oblique way, it makes the stenosis rate much lower than in a plain way. Then, because the distal part is free, so then you can turn it out over and make another here to toe stitching. So we already made the stitch at the 12 and the 6 o'clock, then the 3rd o'clock. Still use interrupted suturing. And the square knot. It's an intima to intima overt anastomose. In 1 o'clock. and the 2 o'clock point. Because this is a extracranial anastomosis, so you can move the vessel freely. So then the
Okay. Hello, Dr. Ben, are you there? I think maybe we have the screen frozen. Dr. Ben, can you hear me? I believe Dr. Ben has to reboot and come back in. Just hold on a minute. We'll get it straightened away. Yeah, he's fallen off, so he'll be back. Just wait a second. Yeah, he fell off, so he'll be back. So it's a coffee break, tea break. We had a temporary internet stoppage. We expect Dr. Ben to come back momentarily.
This is pretty. Oh, I think it's because he...
Okay, still awaiting. Okay, Dr. Bin is back. I believe he's back. Are you there, Dr. Bin? Perhaps I'm mistaken. Okay, Dr. Bin, are you there? Still waiting, Dr. Bin. He fell off. Hello, Juha, are you there?
I'm here. I'm here.
Oh, okay. Yeah, I think Dr. Bin fell off there. And we'll just wait a minute for him to come back.
Yeah, yeah.
Okay, still waiting for Dr. Bin to come back. It's happened before and he's come back. Yeah, let me try texting Dr. Bin. Okay, here he is. Here he is. He's back. Back with a vengeance. Okay, Dr. Bin, are you in? Can you hear me, Dr. Bin? Okay, I think he's taken over. Okay, okay, you started screen sharing. Great. Hello, Dr. Bin. Hello, hello. Looks like you're trying to start screen sharing, but it's not working, Dr. Bin. Start screen sharing again. One more time. Okay, there you go. Come on. Hi, Dr. Bin, can you hear me? It looks like I'm not getting a sound from you. I can see you're starting to screen share, but it's not continuing. Yeah, you've got a low bandwidth. You could try it. Yes, Ben. Can you hear me, Dr. Ben? what we could do is go on with Lewis's presentation, Dr. Ben, and then continue on with yours. What do you think, Juha?
I think Louis could do his lecture when we are waiting for.
Okay. Why don't we go ahead? Louis, are you there?
Just inform.
Louis, are you there?
Louis seems to be there, yeah. But I cannot hear his voice.
Hello, Louis.
Should open.
Hello, Louis, are you there? Oh, hey, Louis stepped away too, I guess.
Louis is speaking, but we cannot hear anything.
Okay.
He's speaking.
Oh, there you go. Okay, okay, Louis, unmute there. You got to unmute, Louis.
Same
there you
Spanish.
Go. Okay. Okay, you're unmuted, Louis, but I can't hear you. You're unmuted. Can't hear you, Louis. Okay, we can see you. Louis, you got to play with your volume. You on your computer, you need to adjust your volume because the problem's in your computer. It's not in the I have it hooked up to the audio on Zoom, but I'm not getting feedback from you.
抱歉啊，因为这个看来还是一个。
Oh, okay. Here's Dr. Ben.
Yeah.
Okay, you want to continue, Dr. Ben?
Yeah, but I'm not sure because maybe the video is too large, the file is too large. So actually, I can see very well in my computer, but
yeah. Okay, there we go. We can see it now. We can see it now.
Okay.
Yeah, Ben, we cannot hear. Are we supposed to hear?
Yeah.
Okay.
So I'm worried about the file size is too large, so it happened the second time that when I play the video, it stopped.
Okay.
So now it's done. You can see now it's the anastomosis is finished. So thank you anyway. So maybe I will update my internet connection. Maybe the Zoom is not
okay. No
big
problem.
enough for my video file.
Well, no problem. This is a learning experience in all areas, not only neurosurgery, but technology. Okay, let's move on
now
to
we'll stop the sharing. Yeah.
Okay, we'll go on to, do you want to entertain some questions now, Dr. Ben?
Yeah. No problem.
Okay, any questions or comments from the audience, please, panelists? We put everybody asleep, I think, by the delay. No comments or questions?
Yeah. Okay.
That's okay. Okay, very good. We'll move on now.
Okay.
Lewis says we got to conquer Lewis. Lewis, are you there? Lewis is having problems with audio too. Let me see here. Can you hear me, Lewis? Hold on. Let me try to track Lewis down. Okay. Trying to find Lewis here. Hang on. I think, Lewis, are you there? Okay, I'm sorry, folks. We seem to have lost Lewis. We'll just wait a second here. Okay, let me try to connect with Lewis by WhatsApp. It's a very effective way to reach him. Just give me a second. Let me get a hold of Lewis on WhatsApp. He's pretty good about that.
So in future, we will have these webinars 8 o'clock Friday, China time.
Yeah.
Always 8 o'clock. We have decided to begin earlier because it may run too late. So it is good time after dinner in China to serve the Chinese audience better. We have decided to begin always 8 o'clock. Subin was recommending that, and I think this is good decision when we have some technical problems, so it may be delayed. So now we are still in proper time limits.
这一周开始呢，因为我们和Juha教授商量，就是把9点钟的讲课呢提前1个小时到8点钟，这样的话呢，大家吃过晚饭以后可以更好的听课，否则9点钟的话呢，相对来说太晚了。
So next Friday we take posterior communicating artery aneurysm part 2, and Subin continues with the bypass techniques, and I hope also the endovascular surgeons from Henan Provincial People's Hospital join us next week, and this would be the program for the next Friday, 8 o'clock p.m. Chinese time. This is how we are doing. Let's see if John can connect Lewis.
Lewis writes back, Juha, and says his connection is bad today, and that he'll do it next Friday.
Okay. Then we.
Yeah, we'll wrap it up. We'll wrap it up now. Thank you very much, Juha. Thank you, Hugo, and thank you, Ben, not only for presenting but for translating to the Chinese audience. So thank you very much, and we'll see you next
John,
Friday.
I can find the Louis name in the audience list.
Okay, yeah, I'll do it. But Lewis said, okay, I'll be glad to try it. Why not? That's my attitude. Why not? I don't see Lewis there.
I think it's on the attendees.
Does anybody else see Lewis there?
On the attendees list, not on the panelists, on the attendees.
Yeah. In the audience.
Yeah, I think, yeah, he says he has poor internet connection, Ben. So we'll just do it next Friday.
Okay. So thank you
very much, everybody.
Thank you
very much.
Thank you. Bye.
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 Okay. Yeah, we could either keep it at 7 or 8 or 7, whatever you want. whichever you
No,
want.
it is 8 o'clock.
Okay, that's fine.
8 o'clock is the time after Chinese dinner. Have the Chinese people better, audience better.
8点钟我们继续
Okay.
连线。
Juha, are you a Chinese food lover?
I decrease in weight with Chinese food. This is good.
Oh, I love it. I could eat it every day.
Okay.
Okay.
Yeah, wonton soup, man. It's whenever you're ill, wonton soup is the best.
So
John,
thank you everybody.
welcome to
Next
China.
Friday again.
Yeah.
Well, Ben, anything you want to do, if you want to do grand rounds from your hospital,
Okay.
we could do that if you want.
Okay.
Once a week, and we could do it in Chinese or English,
yeah.
whatever you want.
Yeah. Okay. Thank you, John. Bye-bye.
Okay, thanks,
Thank you,
everybody.
Juha.
Thank you.
How you doing, Ming Lee? I haven't met you. How you doing? Ming Lee, are you there?
I'm
Ming.
good. Yeah. Yes, I'm here.
Where
Can you
are
hear
you
me?
from? Where are you from, Ming?
I'm from Henan, same hospital. Yeah.
Okay.
You
I'm from
already come
China.
back to China? Okay. Great.
Yes. Yeah, I have been working in Mass General Hospital for 3 years, but right now I will start my work in China soon.
Very good.
Yeah.
Welcome. Yeah, we can
Thank
make more
you.
Chinese panelists. What do the numbers look like, Ben, on that side?
Now it's okay, but
How many people we get from WeChat?
okay, let me check.
Maybe 20,000.
Let me check.
Can you tell, Ben?
Now it's 20,594.
Oh, wow. Well, you know, it's funny. We went down. We went 10,000 to 5,000 and back to 20.
Yeah.
Oh, okay. Maybe we promoted better this time.
No.
No?
For this Syria, now it's 20,596 totally for its cumulative number for this Syria.
Oh,
yeah.
Okay.
It's 20,000.
So are you happy with
598? Yeah.
40,000?
20,000.
Oh, okay. So are you happy with those numbers, Ben?
Yeah. Yeah.
Yeah, we could get the same numbers for your hospital.
Yeah.
Yeah,
Okay.
we could do it.
Yeah.
We could do it.
Yeah. Thank you.
Ya estoy aquí otra vez.
Hey, Luis, ¿cómo estás?
Bien, ¿me escuchas? I am here. I am ready.
Sí, pero estamos terminado. Okay, la próxima semana, okay?
Okay, next week. Okay, excuse me, everybody.
Okay.
Thank you very much.
Okay, well, si tú quieres dar ahora, está bien conmigo. So
Sí.
tú quieres, how about, because we have a lot of panelists here, we have like 37 panelists, so you can present now.
It's possible present now, yes?
Yeah, okay.
I am ready. I am ready.
Okay, let me introduce you, okay?
Okay.
Hi, I'd like to introduce Luis Lopez Ibor, a neurosurgeon from Madrid, Spain, who I met first when he invited me to televise his conference that he has every year in January for neurointerventional radiology. And I have the pleasure today of welcoming Luis back to present at a friend of his webcast, Juha, who speaks at his conference, and maybe we can get him to come this year. Anyways, welcome, Luis. It's all yours.
Okay, just a minute. Yes, is this. Compartir. Okay, just a minute. A ver qué pasa. This. I think tengo problemas.
Oh, ya tenés problemas.
I have some problem. I don't know why.
Okay, sigue tratando.
Okay.
Okay, va a su presentación. Tú va a Zoom, no va a Zoom, no va.
Voy a presentación.
Salga esto, empieza otra vez. Eso es.
¿Está aquí ya? Ok, la presentación.
Sí, está bien ahora, sí.
Ok. ¿Es okay?
Sí, perfecto.
Perfecto, okay. Good afternoon, everybody. Thank you very much, Professor Hennes Niemi, Professor Shubin, and Dr. Hugo Andrade for inviting me. I am endovascular neurointerventional radiologist. And for me, the neurosurgery is the best. I love the neurosurgery, but I am only endovascular neuroradiologist. Okay, I present endoluminal reconstruction of the dissecting aneurysms localized in vertebrovascular territory. This type of aneurysms have two important points. One is hemodynamic impact, and second is the recanalization, because it's dissecting aneurysms. This origin of dissecting aneurysms is possible secondary to trauma, also sometimes it's spontaneous. 1 to 10% have a subarachnoid hemorrhagic. The prognostic is very poor because the patient rebleeding, 70% rebleeding, and 50% in the first week after the first bleeding. This is a very problematic situation to the patient because I have a high risk of bleeding and death. I like to present, this is the precoce bleeding in 1 week and 700% in 24 hours. Also I need, in my opinion, personal experience, I need to treat it in emergency situation, no delay, because it's very poor, the wall of the aneurysm. This is the situation. This is the dissection of the intima, and then the blood flowing not only in this part, also in the medium. And this is the high risk to rupture. This is the problem. I present some examples. This is a junction vertebrovascular aneurysm. This is probably post-traumatic. You are the pica origin in the sac, if you want. The point of dissection is this point to this. This is the angio in lateral view. The pica oblique. The Ica, probably the dissection finished here in this point, no here. And the origin is about this. I decided to treat it with some Leo stent, is French bad company. This is the Cta Reconstruction. This is axial view. This is the Leo stent, and this is the aneurysm. The lateral reconstruction. This is the second Leo. This is the reason you are too marker, axial view, and some week later, you are reduction of the size of the aneurysm, control angio, AP view, before, after 1 week, and the patient is protected from this situation. Okay, another example. This is left vertebral basilar aneurysm, dissecting aneurysm. Also have a small dissection aneurysm in distal part of right vertebral. And this is the right vertebral, this is the pica, and this is the second aneurysm. Lateral view to the left side. The dissection is coming to this point, to this point. I decided to treat it with Leo stent also. And when I finish the treatment, I check the right side aneurysm and look, have a decrease the size of the aneurysm. Probably is the phenomenon of theory of Bernoulli effect. You have more high flow in this side and you are less flow in this side. I don't know why, but change the flow in the region. 1 month later, the aneurysm is totally reconstruction of the vessel. This is the 2 Leo stent also. This is before, after 1 week, after 1 month, totally disappear the right side dissecting aneurysm. Probably to change the flow in the region. Also, some cases more difficult because when you put the stent is possible move in the vertebral or basilar artery. This is the reason because I used one time assisted balloon remodeling technique. This is a 30-year-old male. This is the MRI CT scanner in acute phase. And in the angio, you are this dissecting aneurysm in the right pica. 3D reconstruction, the dissecting point is to this part, to this part. This is lateral view. It's a similar to blister aneurysm. And it's spontaneous, it's not traumatic, this case. When I decided to put the microcatheter with balloon here, the problem when you remove the lead wire support the catheter, is possible you going out with the stent here. I decide to use a balloon to protect when I detach the stent. This is the vertebral, basilar, pica, aneurysm. This is the catheter in distal part of the pica with the guide wire. This is the balloon expandable stent, cardiac stent. Why I decide to use this and nor autoexpandable stent? I decided to use the balloon expandable stent because because it's more precise to place the stent, just this part to this part. I open the stent without inflate the balloon, but when I move the guide wire, some in the cerebral and the placement of the stent, I decide to inflate the balloon and remove the catheter and the guide wire. And this is the final control. You have some spasm, and this part is total recovery. This is the control. And occluded. This is before, this is after. After. And very good flow in the territory of the pica. Other dissecting spontaneous aneurysm. This is the particular situation. It's an aneurysm. I put one neuroform stent, semi-atlas, similar, is autoexpandible stent and some coiling. But 1 month later, I reopen. This is no, it's not stable. This is proximal part of the stent. This is distal part. And 1 month later, this is before a new sac. I decide to use a balloon cardiac stent, if you want, to deploy in this part, lateral view. And you have this effect, real effect. You have the balloon expandable stent here, auto-expandable here, lateral view. Before the second stent, after the second stent. And this is the control. Another case is presented the past 3 weeks, the chest pain genus basilar aneurysm with mass effect in the thalamo mesencephalo with gliosis, partial thrombus. The patient have a thalamic dementia and progressive dementia, trouble in the speak and memory. This is the aneurysm in AP view, lateral view, don't have the posterior communicant artery functional. In the end of the aneurysm, you are the superior cerebral artery and the posterior cerebral artery. This is magnification. You are the superior cerebral artery, and this is posterior cerebral artery. I decide to put the catheter in the posterior cerebral artery to deploy 1, 2 or more stents. Is not used in this period the flow diverter because the size of the distal artery is too small and the proximal basilar artery is normal, 3.5 millimeters. This is the road mapping. First, Leo stent. Second, two more Leo stent, total 4 Leo stent, and 2 more stent to have a good compact packing in the aneurysm. This is the initial aneurysm. This is the control. Initial, 3 months later, 6 months later, total reconstruction of the vessel. But this is the final control, 1 week later, but 1 year later, regrow the aneurysm. And what happened? You had a endolink. It's appeared 1 year later. The endolink is in this point, also in this part. I decide bypass. Don't have the professor Shimbu or Hannes near me. More flow diverter. The problem is the thrombus, overlapping stent, or proximal occlusion, or holidays. I decide the overlapping stent. When I overlap more stent, after deploy, the patient have a thrombus in the distal part. I decide to angioplasty in this part. And during angioplasty, the vessel is ruptured. At this moment, I decide to sacrifice the posterior cerebral artery and closing the vessel because the patient bleeding. 1 week later, the patient dead. Now, this is infection in the posterior cerebral territory. This is a complication. Other patient, dissecting aneurysm. This is the point of dissection to distant. AP view and lateral view. I treated also with the stent and coils, but some months later, reopening the aneurysm because the stent going in the sac. I decide to put the endocardiac stent. Is the case. Axial reconstruction, lateral reconstruction. Lateral and axial. This is the angio control with the reconstruction, endoluminal reconstruction of the basilar dissecting aneurysm. This is to see the flow. What happened with the flow? This is the flow inside the aneurysm after the stent, the second, the cardiac stent. The flow disappears. Okay, this is some example of dissecting aneurysm in vertebrovascular territory. Thank you very much for your attention.
Okay, Luis, thank you. Let me see here. I got you off the screen there. Okay. Let me just get you off the screen there, Louis. Okay.
Yes, just a minute.
Yeah. I got it. I got it. There we go. Okay, very good. Very good. Okay, any comments or questions from the panelists, please? Okay, a quiet panel. Louis, are you going to have your conference this year?
Luis?
Oh, I'm sorry. Go ahead. Go ahead, Ben. Go ahead.
Yeah. So you treat a lot of this posterior circulation aneurysm, dissecting aneurysms. So how about the occlusion rate for the perforators? The long-term follow-up.
Yes, this is a good comment. The perforator, the perforator, when you place a flow diverter, sometimes you're at risk to occlude some perforate, but it's very low this risk. But in dissecting, aneurysm is different because the dissection progress, and you need to change the flow inside the basilar artery because is the dissection is the origin of the thrombosis of the perforated brains.
Yes, I agree with you. For this kind of lesions, the flow diverter normally it's
or a standard stent, whatever you want. Yes.
Yeah.
Yes. Thank you.
Okay, thank you, Ben. More comments or questions from the panelists? Okay, Louis, thank you for being patient with the technology and for giving the presentation. And thanks everyone else. Thanks again, Ben and Juha, if you're still here. And we'll see you all next week. Adios.
Okay, see you next week.
Okay.
Adios.
Bye,
Okay.
bye. Thank you.
Thank you.
Oh, yeah, that's great. That's great.
See you next week.
Next
See
week.
you next week.
Friday, 8 o'clock. Friday,
Perfect.
8 o'clock. Yes.
Perfect.
Okay, Juha, thank you.
Thank you.
Bye-bye. Bye-bye.
Thank you.